For those of you that don't know me, my name is Michael Samarcos. I'm the regional clinical director for Guardian Pharmacy. I work primarily between Orlando and Tampa, so the I-4 corridor. For those of you familiar with Florida, um, it it's a great opportunity to really visit a cross section of long-term care and really be exposed to a lot of it. So hopefully I can bring some of my expertise here to you all, and some of my experiences that I've had with, you know, patients and folks that have been on seizure therapies. So what are we going to do today? What are we going to look at? As I've mentioned, we're going to look at an overview of some of the more common drugs, right? And if you look through these names up on the screen, they're ones that we've seen before. They're ones that we've heard of. Phenytoin and carbamazepine and topiramate and valproic acid and lamotrigine and levetiracetam, and there's some other ones in there, but they've all been around for a while, right? We see them all the time. We see multiples of them on the same patient, and we're going to kind of take a look back as to why those drugs were ordered to begin with, maybe how they work, what doses and stuff we need to be looking for, what do we need to follow with our patients that are on these types of medications. So I think, we're gonna glance over a lot of it. Seizures is such a broad topic, but I want to make sure that we really touch on some of these more common medications that we really do see really in all of our long-term care facilities. We're going to look at some of the mechanism of action of these drugs, right? Because what makes one drug a little bit different from another drug? It's generally how it works. It may have the same conclusion, the same effect, but it might work a little bit differently. And in some people, the drugs that work, a little differently make a big difference in their efficacy. So that's some of the reason we might see, some either combinations or some changes within these medications, depending on how the patient is reacting to the medication, or how the patient is doing just with their seizures in general. So we're going to talk about some of the commonly used rescue medications. I think we touched on that earlier. And we're going to go over some of the side effects of these medications and some of the monitoring parameters, because as we're going to see, some of the monitoring parameters are really what adds a little bit more challenge into dosing these medications. And I can tell you again, from the perspective of a consultant pharmacist, making sure that seizure medication monitoring is up on my list of things that I want to keep track of, because again, if these medications excuse me, end up unmonitored, or for some reason have a drug interaction or something like that, the patient can end up with some poor side effects. So it's something we really want to avoid. Excuse me, I want to apologize in advance. I'm getting over a cold. If you do have a question, feel free to use the Q&A function. I'll try and keep it monitored so I can circle back and answer any questions to the best of my ability. But as we go forward, I welcome interaction, so don't be afraid to ask a question. So what are seizures? Seizures are sudden electrical disturbances, right? So our brain and our neural system, all the nerves in our bodies, it's an electrical conduit, right? We're kind of an electrical circuit all the way through us. And when that circuitry is disturbed, people end up with seizures. So you have seizures, and then you have epilepsy, which epilepsy it's a seizure disorder that's diagnosed when someone has had 2 or more seizures. So as we're going to see, there's different types of seizures. There's different reasons for seizures to happen. And as we kind of parse through some of these reasons and some of these different types of seizures, they'll kind of all end up with the same conclusion. If you have 2 or more seizures, you're then diagnosed as having epilepsy. So super busy slide, but it does a great job reviewing all the aspects of seizure medications, of seizures themselves, right? There's different types. There's different types within the different types of seizures. There's focal onset seizures. What does that mean? What does that sound like, right? Focal onset, the onset of the seizure begins with a disturbance in only one side of the patient's brain. The general onset seizure usually starts when someone is younger, right? So we see it more maybe in children or people that have had seizures their whole lives, and they occur on both sides. Unknown onset seizures are just that. It's someone had a seizure, it was unwitnessed. A seizure maybe that doesn't recur, or if the seizure does recur and it's unwitnessed again or unmonitored, or there's no way to know what the behaviors are and what the seizure, what the effects were of the seizure. It's got that unknown onset. We don't know, where it started or how it started or why it started. Obviously, it prompts people to keep looking further, right? And some of those, especially an adult that has an unknown onset seizure, we want to kind of start looking to see, why did this seizure happen? What do we know about focal onset seizures? Because I really think, between focal and generalized onset, and like I said, generalized onset seizures are seizures that have been around, since the patient was younger generally. And they have all different presentations. As we can see, the presentations between generalized onset seizures and focal onset seizures are very similar. There's the generalized onset seizures kind of tend to be those tonic-clonic seizures, those grand mal seizures that we think about where someone hits the floor, they are, gyrating and moving and gritting their teeth and having all those, I would say stereotypical is not a word I like to use, but it's the kind of symptoms that you think about when someone says seizure. That's usually associated with a motor symptom of a generalized onset seizure. And luckily they're rare, but it's unfortunate for the folks that do have those types of symptoms. When you talk about a focal onset seizure, I think these are the types we see more, especially when we're looking at a senior population, when we're looking at more of a long-term care, with that lens on, whether it's in a skilled facility or in an ALF, or just in a facility that generally tends to have, more older people. Even a memory care could easily fall in this category. But focal onset seizures generally have a cause. It could be a head injury, right? If someone could have fallen, they have a head injury, they have a concussion, and the next thing you know, they have a seizure that they never had before. Well, yes, you have to consider the seizure, and you may have to treat the seizure if it's multiple, but at least you kind of know what the cause is, right? It could be an infection. It could be dehydration. A lot of people have seizures even when they're going through detox. So there's some more benign reasons that we can parse out for some of these focal onset seizures. And of course, there's some less benign reasons, right? Brain tumors are big in there for causing some of these focal onset seizures. So a lot of times that the seizure is the first indicator that the brain tumor is even there. So generally, when one of these focal onset seizures is a new onset seizure, and the reason for the seizure is not overly apparent, we want to make sure that we're looking to see if we can find, the reason that the seizure happened. Strokes are another one, right? We see strokes, especially in our older population, and strokes are affecting the brain. It's affecting the brain. It's affecting that electric field, right? It's affecting all the neurotransmitters and all the balance that normally occurs uh, in our nervous system, and that could cause seizures as well. So as we can see, these focal onset seizures can have reasons. They can have at least visible or traceable indications. You can be aware that you're having a focal onset seizure. So some people know and are aware that the seizure is occurring, whether it's, a motor onset seizure, which means that the symptoms of the seizure, are involving some type of muscle movement, right? And if you're aware and you can kind of wait for the seizure to run its course. You can get some treatment. You can, voice your concern to someone that, I'm having a seizure. Can you please help me? Uh, there's impaired awareness in some of these focal onset seizures, and really you can either witness or not witness any type of uh, symptom for an impaired awareness seizure, but ultimately the patient is unaware. The patient appears to be daydreaming. The patient, kind of has a blank look on their face while they're having either a motor or maybe a non-motor onset type of symptom going along with their impaired awareness focal onset seizure. So again, as we can see, seizures are broad. They're defined as kind of generally. And as we get into looking at the medications, it's important to know what type of seizure we're treating. But even as we look at the medications, we're going to see that they generally kind of cross over back and forth, right? Some medications treat all types of seizures. Some medications treat specific types of seizures. Some medications treat seizures specifically in children. So it's good to know from a clinical standpoint what type of seizure that our patient is having or has had, so that their diagnosis and or their medication matches up with their diagnosis, and we're sure that they're being treated appropriately. Oh, excuse me. So we kind of touched on this already, right? Drug selection uh, basically depends on the seizure type. So we talked about focal seizures, we talk about generalized seizures. The absence seizures is a subset of generalized seizures. But if you look at the commonly used medications, and it's the commonly used medications that we've already touched on, the carbamazepines and the lamotrigines and the gabapentins and the topiramates and the valproic acids and all those, they're really drugs that we see every day. But what do we see in this chart, right? We see focal seizure, carbamazepine; generalized seizure, carbamazepine; or phenytoin. You know, focal seizure, phenytoin; generalized seizure, phenytoin. And the list goes on. And why is that? Because as we're going to see, some of these mechanisms of action are similar. And when you think about, a disturbance in electrical activity in a patient's nervous system, you have to think about, what do you do to either keep that disturbance from getting out of hand or keep that disturbance from happening in the first place. And that's kind of the focus on how these medications end up working. So really, as you go through, you can see the importance of why identifying the type of seizure that your patient is maybe had or is having is important when it comes to ironing out what the therapy should be. And as we're going to see on the therapies, why they're important, in following what they can do to make sure that the patient remains as close to seizure free or seizure free, which is ultimately the goal. So we're going to talk mostly about maintenance therapies, but a lot of these slides are going to go through even some loading doses. So they're overviews, right? I wanted to make sure that we touch on kind of every part of some of these more common medications and make this a really good refresher so that we kind of have things fresh in our mind. And when we go back and are dealing with the medications or looking at some of our patients and wondering what it is that we should be following, whether it's as a consultant pharmacist or clinician or caregiver, and be able to make some decisions on what the best courses of action are on most of these medications. So carbamazepine, it's a first generation seizure medication. It's been around for a while, right? It's been around a long time. Those indications that we talked about, it's focal onset seizures or generalized seizures, right? The mechanism of action. So it blocks those sodium and potassium channels, really, those without getting too far into it. Sodium potassium channels regulate charges in our nerves. So those channels are important. It kind of sends the signal down the nerve. So if we are kind of blocking those channels, we are weakening the signal. And the theory behind that is the stronger the signal in the nerve, the seizure activity increases. So most of these drugs, because they have a range, right? They have a focus, an effective level. So you need to load them when someone is starting out. And we're going to go through that. Mostly, we're not going to see this in our long-term care facilities. Most of these folks will already have been at some type of steady state level. So it'll just require ongoing monitoring. But a loading dose for carbamazepine, it's dosed by body weight. You 2 to 3 milligrams per kilogram per day. You want to make sure that with carbamazepine, you're staying between a trough level of 6 to 8, right? So the trough dose is the minimum blood level that you want to have in your patient, up to a maximum blood level of 10 or 12, and that's micrograms per milliliter. So it's not a lot, right? And that range, even though it sounds like a lot, it's pretty specific. So when you get over that range, you end up having side effects. When you get under that range, you may not be, you're not in the therapeutic range generally that is helping your patient avoiding having any seizures. So we want to focus on staying in that range. We want to make sure that we're monitoring blood levels regularly. I personally like to monitor them at least every 6 months, which again, no fun for the patient, but something that needs to be done to make sure, that they're staying in that therapeutic range. If you have a patient that's on some of these medications and they have a seizure or they have more seizures than usual, the first thing a provider is generally going to do is monitor some blood levels, right? And see, is something going on with the medication? Is something going on with, the absorption of the drug or the dose of the drug? So, and these are all going to be very similar. So as we get into eslicarbazine, which again sounds a lot like carbamazepine, right? They're all kind of similar. What's its mechanism of action? It blocks sodium and potassium channels, which is going to sound really familiar by the time I'm done going through these medications. It's got a little different dosing, right? You're starting out with 400 milligrams and increasing by a few hundred milligrams until you get to that maintenance range of 800 to 1600 milligrams, which again, that's a broad range, right? So we want to make sure that these drugs are tailored to what our patients need. When you look at some of the side effects, they're pretty much similar for all of these. There's dizziness, there's ataxia, drowsiness, headaches, nausea. And as we're going to see when we're looking at kind of all these medications as a whole, when we exceed the therapeutic levels of these medications is when you're going to start seeing some of these adverse side effects. So again, it's something to be sure that we're monitoring. Again, seizure frequency, liver enzymes. I know with carbamazepine, we had LFTs on there as something to monitor. Why is that? Because these particular medications are liver metabolized. Without getting too far into what that does as far as metabolizing other medications and metabolizing themselves, it changes enzyme levels within the liver. So again, it's definitely something that should be monitored. It's and all these medications kind of fall in to the same boat, really, as far as the monitoring aspects of it. And I dwell on it again as a consultant pharmacist. I just try to make sure that all of my patients that are on these medications stay up to date with their levels to be sure that their ranges are therapeutic. Excuse me. So phenytoin, again, it's another drug that's been around quite some time, right? It works. It does have loading doses. You end up, again, with a maintenance dose of 100 milligrams, usually multiple times a day. Sometimes it's more than that. It's again for focal onset seizures or generalized onset seizures. I mean, it's one of those that can be used for both. And why? Because it's got a similar mechanism of action, right? It affects those sodium channels, which again are regulating the activity in our nerves, in the neurons of the patient. So you want to make sure that again, this one is dosed correctly. This one also has a pretty narrow effective range, right? If we remember carbamazepine, it was 6 to 12 between trough and peak. Phenytoin is 10 to 20 micrograms per ml. So again, it sounds like a big range, but it's really pretty narrow. And you want to make sure that, you're kind of staying in that range to make sure that the drug is effective as it can be. When you get over that 20, you start to get to 25 micrograms per ml, you can start to see signs of toxicity, right? And again, these are similar side effects and toxic side effects that we talked about previously. Add in the nausea and the vomiting, lethargy and confusion, which again, you're affecting, the neurotransmission within someone's brain. So I think all these things are pretty much a given when you're doing that, right? Slurred speech, difficulty moving or walking. So all that stuff is things that need to be monitored. And if you notice those things in your patients that are on these types of medications, you want to make sure that the first thing you do is get a level and monitor to be sure that they're not toxic. And that's the easy reason, or at least an easier reason than some of the other reasons you might be having these types of side effects. So it's a similar theme with most of these medications. Valproic acid is another one that usually we see in our folks that can't swallow. It comes in a liquid. It's a little easier to dose that way, especially if there's feeding tubes or other ways of that folks are getting their medication. So it's not uncommon to see it, especially in a skilled nursing facility. So when you look at the mechanism of action of valproic acid, what do we see again? It's kind of put me on repeat, right? It's blocking sodium and potassium channels. In this particular one, it increases GABA concentrations, and it's just another way that it affects neurotransmission. So again, it's got a little different mechanism of action than some of the others. It might be a little more or less effective, depending on the patient. Toxic symptoms, again, pretty similar, right? So when we're over that range, that therapeutic range, you kind of look for those same indicators that there might be some type of toxicity occurring. So this particular drug has an even broader therapeutic range, right? 10 to 20 sounds like a pretty easy target, or 6 to 12 sounds like an easy target. So valproic acid is 50 to 125 micrograms per ml. So relatively significant, right? Pretty broad range. You can be therapeutic with valproic acid and still be symptomatic and just need a higher dose of the same medication to be more into the therapeutic range. So again, pretty broad. Want to make sure we're monitoring liver function. And again, why liver function? Because, these drugs, for the most part, are metabolized through the liver, and that liver metabolism is something we need to keep an eye on to make sure our livers, their livers, are functioning properly. Lamotrigine is another common seizure medication. I feel like, at this point, you all can probably put me on repeat. It's focal onset seizures and generalized seizures. So going way back to that slide that showed us the different types of seizures and what differentiates them. Really, it's a drug that can be used for both. It blocks those sodium and potassium channels. And this one, they kind of tell you in the dosing that it does have interactions with other medications, right? And one of the medications that it has interactions with is valproate or valproic acid. So you kind of need to know if you're going to start or be monitoring someone that's on lamotrigine, what other drugs that they're on, and make sure that they're not interacting, because the lamotrigine doses can be higher in those folks that are taking interacting medications, because they could either inhibit or decrease the metabolism of lamotrigine within the patient. As we go forward, it also has a range, right? So 3 to 15 micrograms per ml. So they all have that therapeutic window that we want to stay in. Lamotrigine's is kind of closer to zero. So, it's not monitored quite as often. For a trough, obviously, you're looking kind of more for a peak. Want to, again, make sure that some of those side effects that we talked about aren't occurring. And if they are occurring, again, if lamotrigine is the only drug, we want to make sure we get a level on lamotrigine. If lamotrigine is on board with other medications, we want to make sure we're getting levels on all the seizure medications if we see any of those side effects. The other common side effect, really, that occurs with most of these medications is Stevens-Johnson syndrome, which it's an epidermal necrolysis. It's pretty poor outcome when it happens, and it's not especially common, but it does seem to be somewhat common when you just look at the seizure medications as a class. So again, if you're starting someone new, you want to make sure you're keeping an eye on their skin, just in case they are either having a hypersensitivity to any of these medications, or they do begin to have any type of Stevens-Johnson looking type of side effects to the medications. Again, as we talked about, right, there's drug interactions. So if you look at just the bottom line of this slide, where co-administration of certain drugs may need to be avoided or dose adjustments may need to be made. So with carbamazepine and phenobarbital and phenytoin and primidone and valproic acid, some of these we have talked about, some of these we won't talk about, but they could all potentially be on board with a seizure patient. So we want to make sure that, again, we are monitoring any type of drug interactions in these patients, because these drug interactions can increase or decrease the therapeutic levels of the individual medications, and again, either cause side effects, or maybe they decrease the therapeutic level and they end up causing more seizures. So super important that we keep an eye on it. Levetiracetam, I think, is one that is super common anymore. I can age myself and say I remember when it came out. and it was still a brand name only. But that was definitely a long time ago, before the white beard. And again, it's indication for focal or partial onset seizures, right? That doesn't mean that it's not used for other seizures. Generally, we see it used in older residents. It is pretty well tolerated. It is a little easier to dose. Uh, it and it kind of has, a broad therapeutic range. So you're kind of more looking for peaks with levetiracetam, although it's very rare that levels are monitored with this medication unless there's something else going on. If there's any type of renal abnormalities or liver abnormalities, um, you want to dose it exactly like the slide says. It's based on the clinical response. So if you are having a patient that has got relief from seizures and is relatively stable, and it's within the dosing range of the medication, then you're probably in the sweet spot. So monitoring the rest of those things that we talked about, which we generally monitor in most of our patients every 6 months or so, uh, should keep us on top of any possible unfortunate side effects with that medication. So it does make it a little easier to dose and a little easier to monitor. Topiramate also been around a long time, right? It's kind of evolved from a seizure medication to having multiple other uses. But here we'll just talk about its use as a seizure medication. It's was indicated for focal seizures and generalized tonic-clonic seizures. So that's those seizures that we kind of think about, the the falling to the floor, really, you know, uh, the, the stereotypical type of seizures that we think about. I think when we all think about uh, someone that is actually having a seizure, it can be used off label. There's some specific seizure types that it works with. So again, it's got similar mechanisms of action, right? It's blocking those sodium and potassium channels. It affects the GABA receptors. It works at some other receptors. So it's got kind of add-on effects to some of the other seizure medications that stop at just working on those sodium and potassium channels, or, affecting GABA. So it's got a few more things that it does. So therefore, it works better for some people. And again, I think looking at all these medications, we want to really kind of look at the big picture and make sure that we're using the medication that is most appropriate, or that is helping our patient, and or really helping our patient have the most relief, right? We don't want our seizure patients, having multiple seizures. I know I wouldn't want that. I'm sure none of us that are on today would want that for any of our patients. So it's again, it's one of those tools. I know if any of y'all have listened to us talk before, we talk about tools in the toolbox. So I think as we've gone through most of these medications, and topiramate included, it's just another tool. It's another tool in that bag that we can use either together with something else, or on its own, with the ultimate goal of making sure our patients are taken care of. So cannabidiol is actually kind of new to the scene. It's new to the seizure scene. I see it more and more in long-term care facilities. It has a different mechanism of action, right? So it's based on the cannabinoid receptors in our system. So again, we have medical marijuana is kind of all over the news lately, and it has been for a while. But cannabidiol actually works on those cannabinoid receptors that we have, and is a FDA-approved medication that works for a particular type of seizures. And I butcher these names every time, so my apologies. But for Lennox-Gastaut syndrome, and Dravet syndrome. And that's generally a younger population, but if they're controlled, they can stay with this medication. And it doesn't mean you don't see it in older folks in long-term care as well, because again, it's a novel approach to seizure medications that has showed pretty decent effectiveness when it works for that particular patient. So, like everything else, monitoring liver function and that type of thing remains important. The dosing, as you can see here, is kind of broad, but you end up fixing on a maintenance dose, and that generally kind of stays the same. And as long as you're not having seizures, it for some of our seizure patients ends up being an excellent choice. So we've gone through really the key players, right, in just about all of the seizure medications that we see, especially in the long-term care space. I think we can look at our patients, we can look at our med carts, we can say that we're familiar, at least by name, with a lot of these medications. And a lot of these medications, as we all know, and we didn't really go into it because it involved, we're just talking about seizures, but they have other uses too, right? So again, they're common, we see them, but I think something that is becoming more common that we don't see as much of anymore, or that we actually see more of, excuse me, that we didn't used to see as much of, are rescue medications. And what does that mean? When someone is having a seizure, when they're in the middle of a seizure, what do you do? And it's nice actually that there's more options around now. As we look at this chart, it kind of gives a great overview of what's available, right? The old way of trying to treat a seizure was trying to give an oral med, and it's usually a benzodiazepine. So what is the advantage? Easy. It's oral meds are easy. You can carry them around. You can have them with you. If you know you're having a seizure and you're able to swallow, then might be a good choice, right? If you have a caregiver that can identify and you are able to swallow during the seizure, might be a good choice. Disadvantages, I think we could all just focus in on what would possibly be some disadvantages, and that would be, during a seizure, someone taking a pill may not be, top of mind as to what they want to do. What are some of the options? They're the benzodiazepines that we see, all the time: clonazepam, diazepam, lorazepam. Those should all be familiar to us. They're very common. They're effective. But unfortunately, maybe an oral pill during a seizure is not, excuse me, the best option. So there's buccal tablets, right? And for those of you that are not familiar with the difference between oral dosing and buccal dosing, buccal can actually be held between the cheek and the gum and dissolve there and go into your system, where an oral dose should be swallowed. So you think a buccal dose should be a little easier, but most of the buccal dose drugs are only designed to be given in a hospital. So it's not something that's out there, easily used, easily carried around. It's on the list, but it's inconvenient, to say the least. So rectal drugs came out. There's rectal diazepam gel, and this drug came out. It's been a while. It's fast action, right? Because you have when you have rectal administration, you have better absorption. You don't have that lag time waiting for a pill that's been swallowed to get into someone's system and then work. Again, difficult to administer, right? Especially if someone is having, is actively seizing with a lot of muscle movements or, a lot of tonic movements, giving them a rectal uh, gel is it's probably not the easiest thing to do. So, and again, thinking about the uh, just giving it, how that could affect the resident, how that affects the caregiver trying to give it, whether it's safe. There's a lot of things that come into play. It was definitely an advance, right? So it's great that we advanced from, hey, we have some pills when someone is having a seizure, to, hey, we formulated, something that'll actually work. Still a little more challenging to give it. And that brings us to some of the newer options, right? Which are nasal sprays that are rescue medications. And I know if we look at some other disease states, nasal sprays have come into play is a great way to administer medication for a broad range of disease states. But they have come into their own, I think, here in the long-term care space, especially as rescue medications for seizures. But it's a little easier to give some of these single-dose nasal sprays to someone that's having a seizure, and they do end up being effective. So we'll talk about the meds that are available for that, and also the diazepam gel that we touched on here for just a little bit. Um, it's for an active seizure, right? These are rescue medications. So your patient is actively seizing. They're actively seizing. You want to make sure that prior to the seizure, we're aware of what the dosing is, right? We want to know, when we've included the instructions for a diastat rectal gel, to be sure that we are all on board with how to use it. But when someone is seizing, it's quite a few steps to follow to be sure that we're getting them the medication they need. And again, when someone is seizing, introducing a rectal gel may not always be the best or the easiest option. So something to think about. It's out there, it's still available. It is effective if you can get it into the resident. So that part of it is great. But as far as ease of use, I think we've had improvements when it comes to the nasal sprays. So there's nasal diazepam, right? You had rectal diazepam gel. Well, now you have nasal diazepam. And again, it's got the same mechanism of action that all of the benzos do, right? That diazepam does for anxiety or the other things that it's used for. But in seizures, it does help, relaxing those the seizure activity and making sure that that patient is comfortable and safe with the least amount of harm to them. It's comes a couple of different ways. It has some dosing options that definitely have to be familiar with, especially if you had it available to give to a resident. But again, as we can see from our diagram here, it's a small single dose nasal spray, and both of these medications actually that are available this way have similar drug delivery devices. So midazolam is also available as a nasal spray. Again, it's a single dose device. Either midazolam or diazepam nasal sprays have slightly different dosing that we would need to be familiar with as far as the resident. But I personally think, it's definitely a little easier to introduce into someone that's having a seizure. So these are definitely things that are assisting us in taking care of our seizure residents. And much like our other residents with other disease states, we think about our hypoglycemic patients and some of our other folks that have rescue medications. I think we should all try and be a little more familiar with some of the rescue medications that are available for our seizure patients, should they happen to need them. So just uh, because seizures are such a super broad topic, right? There's still treatment trials, there's new medications coming online. They're looking at seizures. This is just the Skyline study, which is a phase 3 clinical study of medication for children, teen, and young adults with Dravet syndrome. And it's for these folks that are already using, up to 4 anti-seizure medications. So there's still work being done trying to help these people, which is definitely positive. Um, some other drugs that we just included here, that uh, some may have gotten through FDA approval by now, but Potiva, which is ezogabine or retigabine. When you look at the mechanism of actions of that, similar, right? Potassium channels in the brain. I think we've talked about sodium and potassium channels, pretty much for the last hour. So shouldn't be a surprise that more medications are coming online that affect those channels just as good, if not better, than some other medications. Uh, Perampanel is another medication that they're looking at, and that works with a different excitatory neurotransmitter, that's glutamate. So again, there's stuff in the pipeline, there's ongoing studies, there's our old reliable drugs that we've already gone through, there's newer rescue medications. So I think overall, as we close here, we just can see that there's kind of a broad selection of tools to use for this disease state. And I know there's a lot, but it's definitely an onus to us to be sure that we're familiar with most of them. So thank you all very much. If you have any questions, please go ahead and enter them into the Q&A. More than happy to answer any questions.